चलो आगे बढ़ते हैं. 41 question. Progressive dyspnea. Again, arterial blood gas analysis reveal chronic hypercapnia. All right. Please remember, whenever there is going to be chronic hypercapnia, what is going to happen? These are receptors. Which are receptors which are going to sense these chemicals as oxygen, hydrogen, and the oxygen? These are nothing but the chemoreceptor. But chemoreceptors are short acting. That means they're going to, if there is a temporary change, they will act upon it, right? If there is a change, sudden change, they are going to act upon it. But if there is a constant change, that means, let's say the CO2 levels are constantly high, they will adapt to it, because long-term changes are going to cause the receptors to adapt to that change. So chemoreceptors, since there is a chronic hypercapnia, they think as if this is the normal carbon dioxide level. So chemoreceptors will be adapted, because it is chronic, they will adapt to new high normal. New high, which will act as a normal, right, to of the CO2 levels, right? So they will adapt to the new high normal CO2 levels, right? But what are the other two you can say stimulus for the peripheral one is going to be decrease in the oxygen concentration, that is PO2 will be decreased, and increase in the H plus ion, which is acidosis, right? If we talk about the central chemoreceptor, it is going to be only and only H plus ion in the CSF, right? That will also not work for the CO2, right? So now they are talking about the, let's say, over the time respiratory drive is shifted to become more dependent on the oxygen levels. They have given that, right? Which of the following receptor is primarily responsible for his respiratory drive? Is it central chemoreceptor? No. Central chemoreceptor cannot be stimulated. Why? Because the direct effect is only going to occur only once the H plus ion is more, right? Which is not going to be seen in the, you can say, patient very quickly. Peripheral chemoreceptors, yes, that is true. In the carotid and aortic bodies, which are going to respond to the oxygen now, lesser oxygen, that is hypoxemia. Hypoxia means lesser oxygen in the tissues. Hypoxemia means lesser oxygen in the blood. Hypoxia in the tissues, hypoxemia, emia literally means blood, right? So whatever changes are occurring, that are occurring in the blood. Remember that. Next, stress receptor in the lung parenchyma. Stress receptor has no role over here. Baroreceptors, they have the role in the BP, not in the respiration per se, right? The answer over here is going to be option B. Next, the easiest one, airway resistance is increased by all the following except histamine, prostaglandin, leukotrienes. They are the inflammatory molecules which are going to cause bronchoconstriction. इसका आंसर किस किसने गलत दिया है जरा बताना. Bronchoconstriction, right? So all these inflammatory markers, they are going to cause bronchoconstriction. But on the other hand, lungs are affected. They are going to decrease the surface tension and causes the dilation of specifically the intrathoracic airway dilation. And they're going to decrease the airway resistance. And that's why the answer over here is going to be lung surfactant. The airway resistance is increased by all these things via decreasing the surface tension, which is going to decrease the airway resistance. Yes. Next, a patient has dead space of 150 ml. ठीक है जी, dead space हो गया 150 ml का. FRC is 3 liter. Tidal volume is 650 ml. All right. ERV, TLC is given. Respiratory rate is given. Alveolar ventilation. How do you calculate alveolar ventilation? Alveolar ventilation will be calculated by whatever tidal volume is there. You have to multiply it by respiratory rate in the minute ventilation. Per minute, how much air is coming? But they have asked about specifically about the alveolar ventilation. Alveolar ventilation means how much air I'm able to exchange with the blood per minute. So exchange means the dead space cannot be exchanged during the alveolar ventilation. So I have to subtract that dead space. So dead space, TV minus dead space, and how many such TVs, that means tidal volumes I'm taking per minute, TV minus dead space into RR. So what is the tidal volume? 650 over here, 150 is the dead space, that becomes 500, right? And respiratory rate kitna hai? 15. So 15 into 5, kitna hua? 7 75, right? So 7.5 liters or 7500 ml, you can say. All right, double zeros attached karo, 7500. So we have liter per minute. I'm going to mark it as 7.5 liters per minute. If I would have asked that only for the minute ventilation, then there is no requirement to subtract the dead space for a minute. But since they have asked about alveolar ventilation means you have to subtract the dead space. Dead space will never be exchanged. It is non-exchanged air. Yes. Okay. The same explanation is given just in the liter per minute. Chalo. Next, which of the following best describes the total lung capacity? That means you took the air forcefully in your lung and you're maintaining that level, right? You're holding maximum of the air into your lung. Whatever amount of air present in your lung at the end of forceful inspiration, right? The amount of air exhaled, no air is going to be exhaled during the TLC. The volume of air remaining in the lung after maximal expiration, no, maximal expiration ke baad you're going to have only and only residual volume present in your lung. Uske baad only the residual volume. The maximum amount of air that lung can hold, that is true. The volume of air exchanged during normal breathing, it has nothing to do with the air exchange. Okay, so please remember it is going to be the option C, which is going to be the answer. The maximum amount of air that is present in my lung after the normal inspiration, right? That is the amount my lungs can hold. That is the maximum amount my lung can hold, right? So option C is going to be the answer. RB is going to be B. Yes. Next, chalo. You have to calculate, in this question, you have to calculate the respiratory quotient. Respiratory quotient. So how to calculate the respiratory quotient? There is a formula. How much carbon dioxide you have produced via utilizing how much oxygen. So how much oxygen is given? Carbon dioxide is given 300 ml, right? So 300 ml carbon dioxide the body is producing via utilizing 270 ml of oxygen. So 300 upon 270, that is going to be 0.9, right? So respiratory quotient is calculated using CO2 eliminated. Basically, what we do, we take the oxygen from the atmosphere, right, and utilize to produce more and more ATPs. While producing more ATPs, there will be waste metabolite which will be produced. That waste metabolite is nothing but carbon dioxide. So, as a metabolite waste or metabolic byproduct, the carbon dioxide will be produced, which will be gone out with the respiration itself, right? So, CO2 eliminated by using how much oxygen? So that is going to be your respiratory quotient, which is in this case, it is going to be 0.9. Usually it is 0.8 to 0.9 because it depends on the diet also. If somebody is taking a pure carbohydrate diet, no fat, no protein at all, then he is going to have the respiratory quotient as 1. Otherwise, if you have mixed diet, it is most probably is going to be 0.8 or 0.9. Okay. So next question. The graph given below shows the normal FEV1 and FVC curve, right? And the disease lung graph also. So abnormal graph represent which of the following? So see over here. First of all, look at the X and Y axis. T means most probably time, right? Why? Because these are the FEV1 and FVC. When we talk about that, these are the dynamic, you can say lung volumes and capacities, right? And this V means must be the volume, okay? How much volume you are taking in. Now see over here, normally I'm taking let's say normal is the A person or the blue wala person, right? He's taking this much air. But in the deceased person, the FEV1 is decreased, okay? So this must be the 1 second. In 1 second, how much volume has been expired by the diseased patient? It is going to be lesser than whatever value volume is there. It is lesser than the normal. So FEV1 is decreased. But what you can see, the FVC is almost normal. Then you have to calculate for identification of the lung type of disease, you can say obstructive or restrictive, you have to calculate Tiffany-Pinelli index. That is nothing but FEV1 percentage. How do you calculate FEV1 percentage? FEV1 upon FVC. FEV1 over here is in the numerator. If you decrease the numerator, keep the denominator almost normal, what is going to happen? What is going to happen? So, what is going to happen? Of course, if you decrease the FEV1 or numerator, of course, the FEV1 percentage also decreases, ratio also decreases. And I told you there is only a type of condition in which the ratio will be decreased. That is nothing but the obstructive lung disease. In the old, the percentage and FEV1 both are going to decrease. All right. So it cannot be, since the ratio will be decreased over here, it cannot be restrictive lung disease. In the restrictive lung disease, either it is going to be normal or it is going to be higher, but it cannot be lower. Remember that. In the restrictive lung disease, the FEV1 percentage, either it is going to be increased or normal, but it will never ever be decreased. Okay, so this is not the RLD. So what are the RLDs? Restrictive lung disease. It is not pulmonary fibrosis or sarcoidosis. Yes, bronchiectasis and COPD both are the obstructive lung disease, but understand over here, bronchiectasis, ectasia means dilatation, right? In the bronchiectasia, what is going to happen? There is going to be dilatation, and both the FEV1 and FVC both are going to reduce because of the mucus plug formation and the accumulation of the mucus. The overall capacity also decreases. So what is going to happen? Both are going to decrease. So this cannot be the bronchoectasia. It is going to be COPD because of the pockets which are going to form in which the mucus will be filled, right? And that's why the overall capacity, vital capacity also decreases, which is not in the condition of COPD, all right? So it is going to be the COPD, which is going to be the answer, option D. Let's move on. All right, 10-year boy, presents with a chronic cough, recurrent respiratory infection, failure to thrive. Sweat, chloride test confirms the diagnosis of cystic fibrosis. So what they're asking is primarily getting affected. What is the defect basically? In which physiological process that they're asking? Cystic fibrosis. C for cystic fibrosis, C for chloride. Please remember that even they have given that sweat chloride testing you have to do, right? So CFTR, that is the cystic fibrosis transregulator gene, which is going to be transmembrane regulator gene, which is going to be affected, and the CFTR channel, which is going to be affected. The CFTR channels are nothing but the chloride channels. The chloride channels will be affected. So it is not the sodium channel, it is not the calcium channel. So even in the question, if you read carefully, they have given the hint there. It is the chloride channel, which is going to be affected. Chloride ion transport across the epithelial membrane of lung, pancreas, sweat gland, everything else is going to get affected. So please remember that. Chloride ions. Next. Which of the following best explains the rise in the blood pressure during the early phase of Valsalva maneuver? Valsalva maneuver. What is Valsalva maneuver? Valsalva maneuver is the forced expiration. I'm trying to get rid of the air, but I'm closing the mouth also. I'm closing the nose also. So the forced expiration against closed glottis. So what is going to happen? If you close the glottis, let's say the patient has to maintain, or the subject has to maintain high pressure in the mercury. We are going to attach his mouth to a mercury manometer, and we will ask the patient, you have to maintain that 40 mmHg for a minute or so, or how long, as long as he can hold the 40 mmHg or maintain that 40 mmHg. Now, as soon as he is going to start the Valsalva maneuver, what is going to happen? Forced expiration again, closed glottis. Glottis is closed, but is doing forceful expiration. Whenever you do expiration or forceful expiration, you're going to compress the airways and alveoli. So there is a compression pressure. The intrathoracic pressure becomes positive. That means the intrathoracic pressure is going to increase. As soon as he starts increasing the intrathoracic pressure or start expiring, what is going to happen? The aorta will be, or the vessels, whatever vessels are there in the thorax, they will be compressed because of the positive pressure. And because of the sudden compression of the aorta, what is going to happen? Whatever fluid was there in the aorta or blood was there in the aorta, it is going to go forward and it will increase the BP suddenly. And as soon as the BP increased, the baroreceptor reflex, we can say baroreflex will be activated, and that is going to act opposite on the heart rate. That is going to decrease the heart rate, which is known as this heart rate will be decreased. That means it is the reflex decrease in the heart rate. So that's why it is called as reflex bradycardia. Because increase in the BP, the heart rate will be decreased. So that will be called as reflex bradycardia. Okay. Throughout the Valsalva maneuver, you can see this changes in the BP and heart rate. As the BP is changing, in the opposite direction, the heart rate will change. You can see over here, right? But after some time, after a few seconds, what is going to happen? The venous return will also be decreased. Why venous return? Because the vena cava are also compressed, right? So yes, the BP has been increased, but after some time, in a few seconds, what is going to happen? Since the vena cava is also compressed, so the venous return will decrease and the cardiac output is going to fall because of Frank-Starling law. And because of that, the BP will be decreased. Reflexly, we are going to increase the heart rate. Reflex tachycardia. Now, as soon as the person stop doing the Valsalva, that means as soon as he start breathing normally, what is going to happen? ITP will come back to normal. That means the ITP will decrease because after expiration, he's going to inspire, no? So what is going to happen? Because of the decrease in the ITP, aortic compression will be decreased again. So that is going to decrease in the blood pressure, which will increase the heart rate, right? Opposite changes which will be seen in the phase 1 and phase 3, right? On the other hand, fourth phase, see over here in the fourth phase, what is going to happen? The venous return will be increased. Again, why? Because preload, the compression on the vena cava is also gone, right? So that is going to cause the increase in the BP. What they have asked, why there is an increase in the BP in the initial phase? It is because of the aortic compression, right? It is because of the aortic compression. Okay, so increase in the left atrial pressure. Sasha, but Mary's law is pathological. This happens normally also, all right? Physiologically also. So increase in the left atrial pressure, kya? No, it is not because of the left atrial or ventricular pressure or volume. Increase in the intrathoracic pressure adding to aortic pressure. Yes, that is true. Compression of the aortic pressure. Increase in the intrathoracic pressure adding to left ventricular. No, it is not going to add up to left ventricular pressure. It is going to add up to the blood pressure, right? So it is going to be option C, which is going to be correct. If you want, you can take the screenshot of it. It is overall, you can say a summary of the Valsalva maneuver. You can see over here. First of all, in the first phase, as soon as it starts expiring against the closed waters, the mean arterial pressure is going to increase, and simultaneously you can see after a few seconds, that means after a fraction of second, you can see that the heart rate start to decrease, right? Then the BP will start to decrease because of the venous compression, right? Which will, via the Frank-Starling law, it is going to decrease the cardiac output, and decreasing the BP, heart rate will be increased, right? On the other hand, in the third phase, what you can see that the BP is further decreasing because over here the Valsalva has been stopped. So this gray part is what the patient is doing Valsalva for that much of the duration. Over here, they have written it as 10 seconds. So this phase over here is none other than your third phase. In that, the BP will be suddenly dropping down. Why? Because again, the patient started breathing normally, ITP is decreased, and over here, the preload has been increased, so cardiac output will come back to normal, right? So this is how the summary of the, you can say, Valsalva maneuver goes. Now, figure shows 3 different compliance curve. What was the compliance, by the way? How much volume change you can see when you change per unit pressure. Compliance is delta V by delta P, right? Volume change, how much volume change you can see in the lung after changing a particular pressure, right? So isolated lung, subject various transpulmonary pressure. All right, following best describe the relative compliances. I told you, just extrapolate the X and Y axis, you'll get to the answer. Compliance, if you have more volume change, let's say this is the pressure level. At this pressure change from 0, in the, you can say, U curve, you have a lesser volume change. The volume is changing less. That means the ratio is also going to change lesser. Why? That is going to be present in the numerator. So that's why as the volume is going to change, because I'm taking the pressure as constant. Okay. So if you see at the T level, T is going to have more volume change. If you look at the S level, it is going to be much more as compared to S, as compared to T and U. So I'm going to say the compliance in the S curve is going to be much more as compared to T, as compared to U, right? So the signs over here is opposite. So this cannot be the answer. Ye bhi nahi ho sakta. This cannot be the answer, right? So S more than T more than U, this is going to be the answer. Okay, simple curve compliance is delta P by delta V by delta P. If you have more volume change in that particular pressure, point that is going to have more compliance, right? You must have remember that we have seen the graph like this. I told you emphysema, old age, and the alpha-1 antitrypsin deficiency. That is the only one, that these are the only three conditions in which the compliance is going to be increased. Compliance means increase in the stretchability or distensibility. This is normal, right? If it is increased compliance, means it is emphysema, old age, or alpha-1 antitrypsin deficiency. If it is a decreased compliance, all other diseases, parenchymal diseases, all right? So it is going to be option D over here.